Hi, this is DERM on RheumNow.com. I'm Dr. Jack Cush, executive editor of RheumNow.com. This podcast is dedicated to those of you who are dermatologists and skin-deep HCPs. RheumNow covers a lot of dermatology, so we're doing a dermatology podcast. This week on the podcast, we'll be discussing hydroxychloroquine, the safety of JAK inhibitors versus TNF inhibitors, the SMART study about how to best use methotrexate. What do I think about diets, especially vegan diets, and could that help you? And then what about the safety of IL-17 inhibitors? And lastly, good news on alopecia areata. So let's start with the SMILE study. That was just published this past week. The SMILE study is a randomized, placebo-controlled trial of hydroxychloroquine in patients with incomplete lupus. It's a phase 2 multi-center trial. Took a number of years to accrue this data. It was sort of started and hampered by COVID. Ultimately, they included 187 patients who had incomplete lupus, meaning they were ANA positive, plus they had 1 or 2 SLIC criteria, but did not qualify to meet criteria for lupus. They basically analyzed the data on half the patients being on hydroxychloroquine and placebo. Mean age was about 33 years. They were mostly female, as you would imagine. And if you looked at the end, there was no difference in progression to lupus if you were on hydroxychloroquine or on placebo. About 20% of the patients ultimately progressed to lupus, and it was not significant. Those who did become lupus were notable for having a new malar rash, oral ulcers, joint involvement, and pleurisy, basically meeting all the criteria for lupus. So this is really disappointing because we, and I'm sure you see, a fair number of patients who have some features of LE, and they have ANAs, and it's always been thought it's got to be safe to use hydroxychloroquine, and it is. It's just that it doesn't work, and that's the surprising thing. There'll be sub-analyses on this to figure out maybe why it didn't work, but right now, that's all we can say. A big meta-analysis, systematic review looked at the safety of JAK inhibitors versus TNF inhibitors when used in head-to-head trials in patients with IMIDs, including skin indications. This was published in, I believe, JAMA Network Open. And in the end, in these head-to-head studies, there was no difference when it came to the risk of serious infections, the rate being about 3 per 100 patient years in both groups, or malignancies, about 1 per 100 patient years in both groups, or MACE, major adverse cardiac events, 0.7 per 100 patient years, not significant. The only thing that was significant between these two when they were in head-to-head trials, there was a higher risk of VTE, venous thromboembolic events, if you're on a JAK inhibitor. And it was low, but it was still significant for JAKs, and we know that to be true. But this is sort of data that, one, puts in perspective what the actual risks of serious infections and MACE events and malignancies are. It's low, and that in contrast to the oral surveillance data found in tofacitinib, this does not show much of a risk. But again, this is not a prospective trial. This is a meta-analysis of head-to-head trials. Still useful data. The SMART study was an important study in rheumatology I think you should know about. It was done in India. It was a single-blind, open-label study that compared the outcomes in RA patients who were either treated with 25 milligrams once a week of methotrexate or 25 milligrams methotrexate given in split doses. So this is a one-time dose versus a split dose. You know, this all started in dermatology. You were the first to use methotrexate, and the earliest regimens were 0.25 milligrams, one pill, given Q12 hours times 3. The idea being that it would be safer or better tolerated. And actually what it did was it gave you more toxicity. And then I guess rheumatology and dermatology ultimately get around to doing single dose. But we know that when you use doses above 15 milligrams or above, that there's very variable absorption. You know, it can be as low as 30% and as high as 80%, and it is not predictable. At doses below 15, it's pretty good absorption. And a lot of people say that at 15 or above, you should probably go with parenteral. But then there's this idea of split dose oral. So in this study of 253 patients, people were started at 15, quickly escalated to 25, and they found that by week 16, there was a significant benefit for those that got the split dose oral. Because we know that when you do that, it's the same as giving parenteral, and that you have really almost 100%, 90+% absorption. And yes, there might be more toxicity when you do that, but in this study, the split dose patients were less likely to need a second DMARD. So at 16 weeks, if they didn't respond with a certain disease activity level, then you could add in a second DMARD. Well, they were less likely to use that on split dose oral compared to single dose oral, and that there was more transaminitis with split dose oral. So again, if you are going to use methotrexate and you get to 15, don't give it as 6 pills once a week on Friday. Give it as 3 BID on Friday, and the patients will get more drug and presumably do better for whatever you're treating them for. A analysis of a French database that contains 34,000 patients treated with an IL-17 inhibitor, and it was over a 5-year period for psoriasis, psoriatic arthritis, ankylosing spondylitis, and JIA. They basically did this analysis to look at the safety in these 34,000 patients on IL-17 and reported that there was no significant association between IL-17 inhibitor use and major adverse cardiac events in the first 6 months of use. And they compared that to what you see with TNF inhibitors, which we know do not carry an increased risk of cardiovascular events. In fact, TNF inhibitors will lower the risk of cardiovascular events. And here it was not different. Now, this is important, I guess, for dermatology because you've experienced this in your literature, especially with briakinumab, which was another ustekinumab-like IL-12/23 inhibitor that didn't make it to market because of concerns about cardiovascular risk. But ustekinumab made it to market with no increased risk of cardiovascular events. Subsequently, IL-17 inhibitors have not been shown to do this, whether they're an A or an F or an AF inhibitor. The same can be said for the IL-23 inhibitors, that it looks good as far as cardiovascular safety. Another report came out, a press release from AbbVie this week on their JAK inhibitor upadacitinib, showing phase 3 results of a phase 3. It's called the UP.-AA trial, meaning upadacitinib and alopecia areata, showing that at 15 and 30 milligrams a day, that 45 and 55% respectively achieved a SALT score of less than 20, which means that there was 80% or more scalp coverage with new hair. These were results at week 24. This is encouraging. I would assume that they're going to go take this to the FDA. And right now you have 3 drugs that are FDA approved for use in alopecia areata. We use the baricitinib, but we're not familiar with ritlecitinib and deruxtecan, which is like ruxolitinib, and their trade names are Litfulo and Lexelvi. Maybe you know that. I'm not familiar with that. But it looks like upadacitinib's on its way to becoming a 4th one that will be included. Last report is on anifrolumab. This is the type 1 alpha interferon therapy that has been FDA approved for use in lupus. I put up a report this week of an open label study of 15 patients with cutaneous lupus that had active disease despite being on hydroxychloroquine and steroids, topical steroids, and they had failed multiple DMARDs. They were all treated with anifrolumab, 300 milligrams IV, Q4 weeks. All of them improved. Their Class A scores decreased from 16 to 1. Their Class D from 5 to 4. These were all significant findings. I said we need double-blind randomized controlled trials on this, and we certainly do, but this is not the first time. Anifrolumab looks very, very good at controlling skin disease in lupus. This is not the first report. There are multiple reports. And also in the news this week was anifrolumab, which is Safnello, is its trade name. It's an IV drug, but they reported the results of a phase 3 sub-Q Safnello or anifrolumab study in lupus, and that looks good. So coming soon to a dermatology clinic near you might be sub-Q anifrolumab that you could use for cutaneous lupus, should that be something you're interested in. I'll leave you with what I think is an inspirational quote from Margaret Mead. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. We'll see you next month with DERM on RheumNow.